An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind, and one of them includes figuring out if part of the heart is suffering from ischemia or has had an infarction. The term ischemia means that blood flow to a tissue has decreased, which results in hypoxia, or insufficient oxygen to that tissue. Whereas infarction goes one step further and means that blood flow has been completely cut off, and this results in necrosis, or cellular death. That typically happens if blood flow has been cut off for about 20 minutes. In the heart, ischemia and infarction can be transmural, affecting the entire thickness of the myocardium. But it can also be subendocardial, affecting just the innermost part of the myocardium, the part just beneath the endocardium. Out of all 4 chambers of the heart, the ECG is most sensitive to transmural or subendocardial ischemia or infarction in the left ventricle, because that's the chamber with the thickest walls and therefore has the most cardiac tissue. Alright, so let's start with subendocardial ischemia, which might happen when there's an incomplete blockage, let's say about 70%, in the coronary artery. In that situation at rest, there's usually enough blood flowing to meet the demand of the myocardium. But during exercise, there's not enough to meet the myocardium's increased demand. In that situation, the subendocardial tissue gets ischemic, because it's the last bit of tissue to get blood from the tiny branches of the coronary arteries as they make their way through the ventricular wall from outside to inside. This condition is called stable angina, because there's ischemia which causes chest pain with exercise, and then it disappears with rest. When there's subendocardial ischemia in a region, it causes ST depressions in the corresponding lead on the ECG. An ST depression is when the J point, which is where the QRS complex meets the ST segment, goes down by at least 0.5 millimeters, or 1/2 of a small box. The ST depression can be upward sloping, downward sloping, or horizontal. In subendocardial ischemia, ST depressions are usually widespread, often affecting leads 1, 2, and V4 through V6. With such widespread involvement, it's tough to determine which coronary artery caused the ST depression. As a little side note, if the ST segment is depressed and curved, it might actually be due to digitalis effect, which is when the patient takes the medication digoxin, rather than being due to subendocardial ischemia. Alright, so next there's transmural ischemia. And this can happen when a coronary artery is narrowed from an atherosclerotic plaque buildup over time. Now, there are 2 parts to this plaque, a hard fibrous cap and a soft cheese-like interior. As the blood flows past the plaque, the fibrous cap can sometimes rip, and that cheesy interior is exposed and considered thrombogenic, meaning that blood clots form on it really quickly, and that can quickly plug up blood flow. This means that this time, none of that wall gets adequate blood flow, and this happens during unstable angina, or during a non-ST elevation myocardial infarction, or NSTEMI for short. The key difference here in an NSTEMI is that the ischemia is so severe that damaged heart cells leak out certain enzymes, like troponin and CKMB. On ECG, both unstable angina and NSTEMIs might show ST depression, as well as T-wave inversions. The ST depression looks similar to the ones in subendocardial ischemia, and the T-wave inversions are usually symmetric and at least 1 millimeter deep, or one little box, and are most noticeable in the chest leads, but can also appear in the limb leads. These also have to happen in at least 2 contiguous leads, meaning adjacent leads. For example, lead V2 and V3 are contiguous, but leads V3 and V5 are not contiguous. They also have to have a dominant R wave, meaning that the R wave has a higher amplitude than the S wave. Now, it actually turns out that a little bit of T wave inversion can be normal, especially in leads 3, AVR, and V1. But any sign of T wave inversion in leads V2 through V6 is considered abnormal. Next, we've got subendocardial infarction. Now, in this case, if the coronary artery remains blocked for around 20 minutes, then the subendocardial cells start to die, and this results in necrosis. And this time, given that there's necrosis, we'd expect there to be leakage of troponins and CKMB. So this would be an infarction without ST elevation, which is again an N-STEMI. And this can also show T-wave inversion. Finally, we have transmural infarction, which happens when a coronary artery becomes completely blocked for greater than about 20 minutes. And this causes transmural necrosis. Within minutes, a transmural infarction leads to ECG changes. The most common would be a T-wave inversion, but there might also be hyperacute T waves, which are large asymmetric T waves that appear in at least 2 contiguous leads. The classic sign of transmural infarction is ST elevation, and when that happens, it's called an ST elevation myocardial infarction, or STEMI. On ECG, the ST elevation at the J point must be over 1 millimeter in any 2 contiguous leads except V2 or V3, where it has to be over 2 millimeters. ST elevation, though, can also be caused by other conditions, like coronary artery vasospasm, left ventricular hypertrophy, and pericarditis. As an example, a 20-year-old physically fit person with a viral illness that gradually develops chest pain and is found to have ST elevation on ECG is actually more likely to have pericarditis than an ST elevation myocardial infarction. Now, transmural infarction can also cause pathologic Q waves to appear on an ECG. Normally, depolarization in the ventricles spreads from the endocardium to the epicardium, and most of that ends up pointing toward the positive electrode, which means a positive deflection. With infarcted tissue, though, it doesn't conduct electricity, which means that the electrode essentially sees through the infarcted tissue, sort of like as if it was just a hole. And it sees through the hole to the other ventricular wall. And since those are mostly moving away from the positive electrode, you end up with this big, negative pathologic Q wave. So pathologic Q waves are those that are longer than 0.04 seconds, or 1 small box, and over 2 millimeters, or 2 small boxes deep. Now, the location of the transmural infarction can be identified based on the lead that has pathologic Q waves. Septal wall infarctions show changes in leads V1 and V2, whereas anterior wall infarctions show changes in leads V3 and V4. Anterolateral wall infarctions show up in leads V3 through V6, as well as 1 in AVL. Small subendocardial infarctions don't actually cause pathologic Q waves, because some of the affected wall still conducts electricity. Also, the AVR lead is oriented in a way that normally produces Q waves, so it's actually not a reliable lead to look for pathologic Q waves. Finally, pathologic Q waves can also result from things other than transmural infarction, like a left bundle branch block and Wolff-Parkinson-White syndrome. After a transmural myocardial infarction, the ECG gradually starts to look more normal. During the first 2 days, there might be T-wave inversion, ST segment elevation, and pathologic Q waves. But around day 3, the ST segment's often back at baseline. After a few weeks or months, the T-wave inversion might start to improve as well. But pathologic Q waves can linger for a lot longer. And this is why it's always important to compare ECGs to previous ones to look for new changes. Alright, as a quick recap. Subendocardial ischemia can reflect stable angina and can cause ST depressions. Transmural ischemia and subendocardial infarction can reflect unstable angina and N-STEMI, and can cause ST depressions and T-wave inversions. Transmural infarction most often reflects a STEMI, and causes T wave inversions and hyperacute T waves, as well as ST elevation and pathologic Q waves.